All right, in this explainer, we are diving deep into a super important topic for your PEBC exam, opportunistic infections in HIV. We're going to cover the critical guidelines for prophylaxis and treatment that you absolutely need to have down cold. So let's jump right in. Here's a quick look at our game plan. We'll kick things off with an intro to OIs, then move into therapy goals and the key investigations you'll need. After that, we hit the really high-yield stuff: when to start prophylaxis, how to manage active infections, and, just as important, when to stop prophylaxis. We'll wrap up with two special topics: iris and pregnancy. Think of this as your clinical roadmap. First things first, let's talk about the foundational concept here. The link between a patient's immune system and their risk of infection is, well, it's everything. As that CD4 count drops, the susceptibility to specific opportunistic infections just skyrockets. This makes the CD4 count an incredibly powerful clue when you're trying to figure out what's going on with the patient. So, what exactly is an opportunistic infection, or OI? Well, just like the name says, it's an infection that takes advantage of an opportunity, in this case, a weakened immune system. And here's something really important to remember for the real world. Even with all our amazing antiretroviral therapies, or ART, an OI is often the very first clue that leads to an HIV diagnosis in someone who didn't know their status. Okay, before we dive any deeper, we have to get two key terms straight. You're going to see these everywhere. First, primary prophylaxis. That's when we use meds to prevent an infection from happening in the first place. Then you have secondary prophylaxis. That's all about preventing an infection that the patient has already had from coming back. Getting this distinction right is absolutely fundamental. So, with those basics covered, let's start building our clinical approach. First step is patient management. What are our goals, and what tests do we need to run to get a clear baseline picture? Our goals here are actually pretty broad. It's not just about preventing and treating infections, though that's a huge part of it. We're also trying to reduce the overall drug burden. That means stopping prophylaxis when it's safe to do so. We also have to be really careful about minimizing drug interactions with their ART. And of course, the overarching goal of preventing HIV transmission. So what does that initial workup look like? Well, first, we get a CD4 count. That tells us about their immune status. Next, we screen for latent or sleeping infections like toxoplasma and TB to see if they're at risk of waking up. We'll also check baseline organ function, like their kidneys and liver, to make sure they can handle the drugs we might prescribe. And finally, some really specific safety tests, like G6PD levels, are crucial before we can even think about using certain alternative drugs like dapsone. All right, now we're getting into the stuff that is prime exam material. The decision to start primary prophylaxis is almost entirely driven by specific CD4 count thresholds. So let's break down the key numbers you need to have locked in your memory. Here it is. The first, and maybe the most important, number you need to know. When a patient's CD4 count dips below 200, we absolutely have to start prophylaxis for the most common life-threatening OI, which is PCP. And our go-to drug for PCP prophylaxis is sulfamethoxazole/trimethoprim, or SMX/TMP for short. The dose is simple: one double-strength tablet once a day. Now, if your patient has a sulfa allergy, you got to know the alternatives, like dapsone or atovaquone, and always be on the lookout for the common side effects of SMX/TMP, like rash or high potassium levels. Okay, the next critical drop point to watch for is a CD4 count falling below 100. Once we hit this level, we need to add another layer of protection, but only for patients who've been exposed to a certain parasite in the past. And here's a fantastic clinical pearl that just makes life easier. For patients who test positive for Toxoplasma IgG, which means they have a past exposure, that same SMX/TMP regimen we already started for PCP also gives them excellent protection against toxoplasmosis. It's a 2-for-1 deal, which makes it the clear preferred choice. And finally, we get to the threshold that signals the most severe level of immunosuppression, a CD4 count below 50. This is a major red flag, and it means we need to protect against a very serious, disseminated mycobacterial disease. For Mycobacterium avium complex, or MAC, the top choice is azithromycin, 1,200 milligrams once a week. Now, here's an important caveat. If a patient is starting effective ART right away, you might not even need this prophylaxis. Why? Because the goal becomes getting their immune system back online as fast as possible. Okay, let's switch gears. We've talked a lot about prevention, but what happens when a patient shows up with an active infection? Let's walk through a common and very serious clinical scenario to see how we go from diagnosis to treatment. Now, I know this chart looks a little intense, but let's just trace the logic together. Picture this. A patient comes in with a fever, some kind of neurologic symptom, and we know their CD4 count is under 200. The first big decision point is the brain scan, a CT or MRI. Now, follow the path to the left. If we see no focal lesions, the next step is a lumbar puncture. But follow the path to the right. If we do see focal lesions, our thinking immediately shifts to toxoplasmosis. A positive serology then leads us to start empiric treatment. This flowchart is your guide. So for treating active PCP, we're back to our old friend SMX/TMP. But, and this is a huge but, look at that dose. It's a much, much higher weight-based treatment dose, and it's given for a full 21 days. At these high doses, you have to be on high alert for serious toxicities, like high potassium and kidney damage. For really severe cases of PCP, we've got another vital tool in our belt, adjunctive corticosteroids. The indication here is crystal clear. If the patient is hypoxic, meaning their PaO2 is less than 70, or their AA gradient is over 35, we add prednisolone. This has been shown to dramatically decrease inflammation in the lungs and improve patient outcomes. Now for the really satisfying part of the job. Once a patient is on ART and their immune system starts to recover, we can actually start de-prescribing. So let's look at the specific criteria for when it's safe to stop these prophylaxis medications. Okay, you're definitely going to want to focus on this slide for the exam. For PCP and primary toxoprophylaxis, the magic number is a CD4 count over 200 for at least 3 months. But notice how the rules get a little stricter for secondary prophylaxis. For toxo and MAC, we need a longer period of immune recovery, plus we need to make sure they've completed their initial treatment course. These are the numbers to memorize. To wrap things up, let's quickly touch on 2 important special situations that you'll definitely encounter in practice and on exams: immune reconstitution inflammatory syndrome, or IRIS, and how we manage OIs during pregnancy. So what on earth is IRIS? Well, it's a little paradoxical. You start a patient on ART, and their immune system starts to roar back to life, which is great. But as it wakes up, it can suddenly see a pre-existing infection that was hiding out, and it mounts this massive inflammatory response. This can actually make the patient's symptoms temporarily worse, usually in the first few months of starting therapy, especially in those who started with a really low CD4 count. And what about pregnancy? The guiding principle here is always to treat the mother effectively while minimizing any risk to the fetus. For major infections like PCP and MAC, we do have preferred agents that are considered safe. The huge takeaway for SMX/TMP is the absolute necessity of giving folic acid supplements, especially during that critical first trimester, to help prevent birth defects. Let's finish up with a quick case to see if you've got this down. A patient's CD4 is 225. They finished a full 12-month treatment for MAC disease 8 months ago. So, based on the criteria we just went over, can you safely stop their secondary MAC prophylaxis? Pause and really think it through. When you can confidently apply these discontinuation rules, you'll know you've mastered the key points from this explainer.